So, can you hear me? Yeah, nay. Okay. So, Amy said that she lost half the room, and I think I've lost almost the other half. So, um, introduce myself real quickly. So, I'm Robin Curnel, and I'm one of the advisors here at the REC. I'm an RN by trade for many years, and we'll just leave it at that. Thank you so much for your attention today and being here. Thank you to those who are attending virtually. I wanted to do a real quick recap of what I've learned today. So I have a 9-foot tree. I don't have enough lights. I'm tickled that we have an elder care program here at UK. I think that's something we could put all across the state. I am not a perfectionist, but I live with two who are, even though we're not supposed to identify that in others, but that's the truth. And then I am so thankful that Amy works for us and not the ONC. I mean, let's be real. I mean, do you want her coming to do your audit? She's brilliant, and we're tickled. And then we've got Christina, who's trying to share with me all of her knowledge on hospital PI, and God bless her, it's just not sinking in yet. So you got me for telehealth today, and I appreciate you for staying. I know that I am what's between you and your car. So I'll be real, and I'll be quick. And by all means, ask questions, interrupt me as we go. I can handle it. So just a real brief introduction about what we're talking about today, telehealth and what it looks like now. Most of you all are very well experienced in what we're doing. Some latest legislative updates, slow down, and some long-term solutions that we can help you with. So we know what telehealth in 2021's been like. It's evolved. You know, the REC was talking about telehealth before COVID hit. We were talking about it pre-pandemic. Is this something that we can help folks with? Is this something we're going to see really evolve? And then here come COVID and hit us all like a ton of bricks. Fortunately, with current policies and these waivers in place, it's really opened it up and made it very flexible for providers. It's made it very flexible for patients and improved, significant amount of access to care. So just some top highlights that I've put up here. If QHCs and rural health clinics are now can be distant sites, and that's going to be a permanent solution, whereas it's not been. It opened up who could be your distant site providers, and it include a multitude of professionals, and who's not listed here are also your therapies, your OT and your PT and your speech. They're all providing services telehealth at one point. And currently, there's over 270 services on the telehealth service list. About 160 of those will be made permanent. The others, it's still a little early. Yes, sir.
We're going to have to pause.
Okay.
So, because otherwise it's going to cut off mid-presentation.
Fine.
So we got to switch for our hybrid folks.
Okay.
Online. So we just got to take a quick moment to swap over. We're good?
Are we good?
All right. We should be good to go.
We're good? Okay, great. Fantastic. I like things that just move like that. Anyway, as far as the services, there's many of them that will stay permanent. There'll be some others that I think over time and as additional final rulings get released, we'll see additional services get made permanent, and we'll see some interim federal rulings as well come out. So I have a little bit of animation, but I'm going to click them all up just to get through it. So currently we know patients can access telehealth from home. And why is that a big deal? Well, Medicare patients couldn't before, so now they can. Your commercial payers have been able to do that, but Medicare patients could not. We can use our smartphones. We can still use those for FaceTime and Skype. I don't know how much longer we're going to be able to do that because of HIPAA compliancy, but right now we can still do that. Audio-only visits became reimbursable. They aren't reimbursed at the same level as an in-person one, but they are reimbursable. And they've released that established patient restriction. So prior to COVID, you had to have an established relationship with the patient. You had to have at least seen them in your office at least one time. You can still reduce your cost sharing so that patient responsibility can be waived. And then all providers are eligible to use telehealth, as we mentioned earlier. I will tell you that I've seen some updates come out about telehealth fraud. And I don't have it in a slide, but they're looking at billing. So just keep that in mind that you're adding your correct modifiers and things, because I know those continually have evolved throughout the whole last 2 years. When we talk about the state for Kentucky, it is much more relaxed than what Medicare is when it comes to payment parity, less restrictive on patient location guidelines and things of that. And then, of course, we've got a more robust, but currently improving state telehealth program. And Andrew, are you part of that too now? I thought so. I've been on a few work groups with that program, and I'm really pleased to be able to do that because I think that's a great partnership between what we can do as far as getting information out to people, but also being involved in some of that policy development. Kentucky's definition of telehealth includes synchronous and asynchronous technology, remote patient monitoring technology, and audio-only encounters. Store and forward is reimbursed by Kentucky Medicaid under certain circumstances, but remote patient monitoring currently is not. And I think that'll change, but just keep in mind that it's not. That's strictly for Medicaid, but that's under the program. So the state has a new website, and they really updated it. When I talk about payment parity, I'm talking about your commercial insurances must reimburse you at that same rate as Medicaid. So before that was an issue, but in Kentucky that's no longer an issue there. The other things that they're working on in the state is licensure for your providers so that you can have providers outside the state. They're trying to work on that compact agreements like we have with nursing. They're trying to do the same thing with providers too, so that expands some access. So patient and provider satisfaction, just a real quick touch base over how perceptions of telehealth have improved over the last couple of years. At first, folks didn't want to do it. They felt like they wouldn't get much time with their provider. They'd be distracted because they'd be on the computer, but many folks have found out they actually get a little more attention. There's not as many distractions coming and going now because the provider's in a room, patient's at home, and so they've got that in there now. Providers are coming around. Some of them aren't super excited about it at the beginning because they didn't know how it works, and there's so many things, and you have buttons to click, and patients can't always get off mute and whatever other things, but it's coming around, and the conversations that I have now, folks are wanting to know what are some more permanent platforms that we can put in place. So it's coming around. I actually had a conversation with somebody in the last couple of weeks that has been really pleased with their teleneuro program because it's expanded care and their patients are able to stay home and stay local. So it's coming around. So some legislative updates. Now, this one is kind of an old slide, so don't take it for what it's for word, but it's not going away. We have senators and representatives who want to keep telehealth. They want to keep it where patients have access. They want to expand broadband. They want to expand it where patients can access it easily. And so there's a multitude of legislations and acts that's been passed or been introduced in committee. Not all of them have made it through, but it's there. I think Michigan has probably got the most people on board federally as far as wanting to expand telehealth. Most recently, under the Infrastructure and Jobs Act that was signed in November, there was $65 billion listed there for broadband funding. And I don't know how it is for where you all live, but I live in a rural area. I'm in the western part of the state, and internet for us is hard. It's the same way for you all in the eastern folks and in the eastern part of the state as well. And our local co-op has applied for funds to run internet along our power lines. I mean, that's a fantastic idea. And the latest update I got was that we will see that in 2 more years. 2 more years, while it's short, still seems like a long time. But it's coming. And I think that part of one of the counties in the eastern part of the state, they have a co-op that already has that in place for some of their folks. So we will continue to see more movement around telehealth, federally. The other thing about telehealth is it seems to get flowered, is what I call it, in all of the final rulings. So it's been in the physician fee schedule. There was some in the IPPS rule. There was a little bit in the OPPS rule. And I think we'll see that throughout 2022 the same way as well. So a little more advice here from the experts. Some of this comes from the advisory board, but essentially we're going to see telehealth used more often, and we're going to see it demanded more, and we may see it demanded more from your employers, more so than your patients. We're already seeing folks being directed towards their commercial payers, directed towards their teleproducts, their teledocs, or whatever that Anthem has, and I think Humana has something similar. And they're doing that because of productivity and cost. So at some point, you'll have to be competitive to keep up with those commercial payers. So in our latest final rule, some takeaways that come from that, they've added HCPCS codes for 22 different services. There are some temporary codes that will remain active through the end of the calendar year in which the public health emergency expires. I mean, how confusing can they make that? So right now, the PHE goes through January, so we'll see those temporary codes allowed through the entire calendar year of 2022. The one thing that I was hoping to see become a permanent structure for folks is that Medicare patients could have their home as their originating site, and they currently do not do that except for one group of patients, and I'll talk about that in a little bit. They made some updates under Medicare related to physiologic monitoring, and as Christina mentioned earlier, when you see those opportunities to comment on those final rules, your feedback is essential. So they do get read, they do get responded to, so when those come out and you have an opportunity, especially around telehealth, be sure and comment on those. This is the one section I talked about becoming permanent. So when it becomes behavioral and mental health care, CMS recognized that for a lot of folks, that just walking into a center for behavioral health care is a struggle. They're concerned about people seeing them walk in, they're embarrassed and things of that nature. So they removed the geographic location requirement for behavioral health care. So it's a start. They are allowing mental health services now to be provided under rural health clinics and FQHCs. They are continuing to allow and made very specific the definition to audio only as a payable service. They still do, however, want at least one in-person visit prior to that first telehealth service visit. So there is that whole established patient requirement there, but they did at least remove that geographic location requirement for behavioral and mental health. So long-term solutions. So is telehealth going to be a fad, or are we going to see this as a permanent part? I really think it's important that we consider telehealth as being a part of your service delivery program, whether you make it a part-time option for afternoons or Saturdays, or if you designate a provider to provide telehealth services 4 hours in the clinic, it's not going to go away, and I think it'll benefit your practices in the long term. Things to consider when you want to make this a permanent access: software platforms. Some of your EHR vendors provide you with a telehealth vendor within their system, others don't. And so you'll want to look at what platform, of course, is HIPAA compliant, but what works best with your EHR vendor, what works best within your facility. And then for you all as a practice, you have to consider technology and broadband access. It's going to take a little more for that audio-video capabilities. And then leadership and staff buy-in. We've been practicing it for the last couple of years, so you wouldn't think this would be as hard. But I think we all still have it in our heads that this is still a temporary thing, that it won't be a permanent solution. And then also right now, your staff are doing so many different things, it's really hard for them to focus on such a thing. So you'll want to consider your staffing models for how you would implement this permanently. And then scheduling. I mentioned it earlier. Do you want to make it a permanent part of your service line, and do you want it to be a full-time, a part-time, and after-hours type project? How do you want to schedule that? Some best uses for telehealth. So it's not a one-size-fits-all model. And what may work for one is not going to work for somebody else, obviously. So think about the intensity of services and the target population. Maybe you just use this for a specific group of folks. Maybe you use this as part of your chronic care model or your TCM model or something to that nature. It's only a certain group of individuals. We talk about urgent care. We talk about mental health already. I've talked about chronic care with your chronic care management that we've mentioned. And then maybe it helps reduce some of your patient backlog. When you think about rooming patients and getting them in and getting their appointments, if you can extend your hours long enough, maybe 4 hours in the afternoon, you may could pick up some of those folks that need their annual checkups, or maybe they need just a prescription refill or something of that nature, that maybe you can catch that backlog up. Now this is where it becomes a little challenging to use it. Medicare has that annual checkup. I can't remember the right term for it, but it's an annual visit they have to complete. Right now, they're still wanting that to be in person. It's still waived during the public health emergency, but at some point, we know that's going to end. And so trying to complete an annual physical may be a little more difficult, but that could be your one visit you get in person, and then the rest of your visits could be telehealth. The next question is, how do you talk about critical labs or imaging? You know, do you have something that is potentially damaging, or could be, you know, how do you tell somebody they've got cancer over a video? I mean, how do you do that? And so some folks find it harder to do, but interestingly, other folks found it a little easier, from what I've read on some surveys, in that they were in their home, they were in a comfortable location, they could have family there with them if they needed to, whereas, you know, in the clinics maybe they couldn't. And so for some, it was an okay place to hear that on a video call, that, you know, your labs have come back and they're serious, and it was a good place for them to hear. So, you know, you kind of have to know your patients and know how they're going to respond and which is the best location. If patients have multiple complex problems, I mean, let's be honest, our patients aren't honest. I mean, I've been a nurse for 26 years. Some days they will tell me one thing and tell the doctor another thing. So when they're managing complex issues, it's sometimes hard to do that through audio, video, or certainly audio only when you're on the phone and they're having trouble hearing you in general. You know, they have trouble hearing in person, and let alone we've put them on a telephone. And then I touched on highly sensitive matters. You know, it could be the other side too. You have to tell somebody something that they're not ready to tell their family yet. They need to process it. So do you need to do that in person, or do you need to do that, you know, through video? And then, of course, you can't do certain procedures. Now, there's telehealth equipment that is very robust that allows you to use a stethoscope or an otoscope or ophthalmoscope, but somebody has to be there to use that equipment. We've got one practice that may be watching us virtually. They were able to open a satellite clinic. They put a nurse down there, and the provider is in one location, the patient and the nurses are down there. And so that nurse can put that equipment on that patient as needed. It saved them time because they don't have a provider driving from one location to another, or they're not busing patients an hour and a half one direction either. So, you know, there's some flexibilities there, and depending on how you want to operate your system. So, how can we help? So one of the programs that we've been working into is how can we help providers with implementation of telehealth to make it a permanent solution. And so we have some multiple options there. I can assess and review your layout of your facility, you know, what's your viability of a telehealth, you know, adoption within your organization. I can help you with designing workflows around your physical locations to deliver those services. We have tools and knowledge to help you with billing and reimbursement, and then providing you with policies and various things like that, and we can help ensure that your program is sustainable. Ultimately, the goal there is to provide and improve access to healthcare services, and telehealth gives you an option to expand your service. And I think I'm getting done a little early. So, these are my new little grandbabies. So I can't let you leave after being bored without some excitement. So they are a week old, and I did have a beach picture there, and I'm like, nobody's going to the beach right now, so we'll throw puppies up there. So I will entertain any questions that anybody has. Yes, ma'am.
So you said that the Medicare annual wellness could not be performed by telephone? Isn't it in the 207 list that can be done by telephone?
It is currently in the list. The question is, can the annual wellness visit, that's the word I was losing, can the annual wellness visit be completed through telehealth? Currently, yes, it can. It's not been made permanent yet into that. It's in that list of 270. I read 2022. Somebody else in the office read 2023. So I'm going through the end of December of 2022.
Okay.
Yes, ma'am.
And just remember with those annual wellness visits, if you're doing them remotely, they do not risk adjust. So that is not always, you want
Okay.
to see those patients in the office, if at all possible, my opinion.
Okay.
Because of payment and reimbursement.
Yeah.
There's a lot to.
There's a comment here, I'm repeating for the virtual folks, is that if you don't see them in the office, that there's potential for not risk adjustment on their billing. Okay. That's a comment that's new to me as well, but I'm not going to dispute it. I'll double check that. But yes, it's currently on the list, but it hasn't been made a permanent option yet. Anybody else? Nope. Okay. Thank you, Jim.
All right.
4 minutes.
There you go. Thank you. And are you performing telehealth on the puppies? How is that working?
No, I'm actually doing exams. I weigh them and everything to make sure they're growing. I've got one that's little.
All right. Well, I appreciate everyone coming out today. Let's give our speakers another round of applause. I hope you all really enjoyed the event. A couple housekeeping items we do have on our app. If you want to provide feedback on any of the sessions, go into the app and you can click through. If you go into the session, there's a survey section you can click, and if you need additional information, leave that in the survey, or if you have any feedback on anything that we said, or you need additional information, put that in there. There's also another place, if you go into CVent and click more, there's forms. So if there's something that you want us to present on, or something you want to hear more about, or something that we could help you provide a service with, just let us know. We're here to support you all as well. So we thank you again for joining us, and look forward to seeing you next time. And everyone, thank you for joining virtually as well. Have a good afternoon or evening.